This is Daniel King, and you're listening to George Fox Talks Wellness. What's going on, George Fox family? It's good to see everybody, hear from everybody. Hey, today I'm so excited about the topic we're going to discuss. I got two very, very special guests with me, and they're actually my colleagues here at George Fox University. We got Dr. Amber Nelson
Woo, woo.
and Dr. Danny Rodriguez.
Hey.
So today what I'm going to do is I'm going to actually have them maybe share a little bit about their professional journey. So I'll start with Dr. Amber Nelson.
Yeah. Hey, y'all. Thank you so much for just hosting this, having this conversation, and asking Dr. Danny and I to be here. We're both really excited to just sit down. We love talking to you. So this is just a great opportunity.
Yeah.
So just to introduce myself, my name is Dr. Amber Nelson, Doc Nelson, Doc. Oops, I hit the mic. Sorry about that. And so my journey has been a long time coming, I think. But I actually did all of my education, undergrad, my master's and my doctorate here at George Fox. Wow. I always say that blue and gold runs through my veins.
Wow.
You can still see me, I think, in some, advertisements and in the background of photos.
Okay. We'll look for
yes,
that.
you have to look for it. You have to look for it. But
yeah.
I did 12 years and 5 degrees here, and just incredibly blessed to now be back, recontributing to this community. But I'm trained as a pediatric psychologist. And I did my postdoc or my doctoral internship with Harvard Medical School and Boston Children's Hospital, specializing in pediatric psychology, working with children, adolescents, young adults with acute and chronic medical conditions. Wow. And then I went on and did my postdoc, and I actually did a 2-year postdoc, which was elected by me. I only had to be 1, but I was like, there's so much more I could do here.
Just another
year,
Right.
So I did a 2-year postdoc with Johns Hopkins Medical School, or School of Medical of Medicine, and with Kennedy Krieger Institute in Baltimore, Maryland. Okay. And I continued doing pediatric psychology, but then I did some emphases in cystic fibrosis and sickle cell disease. I'm really emphasizing kind of health disparities in 2 chronic illnesses that have very different populations that they hit. So that's where I did my training. And then I stayed on there as staff psychology before I came out here and started as faculty.
Wow.
Yeah.
So you came back.
I came back. Yeah.
So you really do bleed blue and gold.
I do bleed blue and gold. Absolutely. Yeah. 100%. Yep.
Well, thank you so much.
Yeah,
How about you, Dr. Danny Rodriguez?
Yeah. Thank you, Dan, for inviting us both on the podcast. Doc and I work really closely together, and getting to do this podcast together is just a really exciting thing.
Yeah.
And then plus, love you. You're awesome. So
appreciate that.
So I am Dr. Danny Rodriguez. My students, a lot of my students and a lot of my patients call me Dr. Danny. So I also have spent a lot of time around Newburgh. I am an alum of both undergrad side and graduate school as well. Wow. So Doc has got me beat as far as the 12 years. I only did about 9, but
we're vets. We're both, George Fox vets.
George Fox vets.
Wow.
So I'm trained as an integrated care psychologist, more kind of full lifespan. I during graduate school, I had rotations in Providence, Newburgh, which is where we first met, as you know, and was there for 2 years. Then also working in community mental health while I was here in Newburgh in graduate training, and then for my doctoral internship, I was placed at Iolalahui, Rural Hawaii Behavioral Health, which is a nonprofit integrated care training program geared towards training psychologists to work with underrepresented, marginalized peoples, particularly the Native Hawaiian population of the Hawaiian Islands. So I was there for internship. My placement was on the windward side of Oahu in a federally qualified health center, Waimanalo Health Center. It's kind of an all-in-one, one-stop shop for medical care, which included primary care. We had psychiatric providers, we had behavioral health, dentistry, optometry, kind of all in one for a really underserved part of the island. Then my postdoctoral year, I also stayed on with Iola, but I was placed on the island of Lanai, which is the smallest populated island in the Hawaiian chain.
Yeah.
About between 2,000 to 3,000 people on island. Fun fact: there's literally more deer on island than there are people. So yeah, so it was kind of wild. But I was placed at another federally qualified health center over there. The Lanai Community Health Center, as one of the few behavioral health providers on island, really serving the community over there. So it's very similar to Doc Nelson, but just kind of working in underserved, very rural areas for populations that really needed as much care as possible, but also very unique settings in Waimanalo, where there's a whole bunch of history about the Hawaiian sovereignty movement, for example, is often based there. And then Lanai is 97% privately owned by billionaire owner, and there's still kind of the remnants of that. So got to see some very unique settings and very unique experiences that I like to think not a lot of healthcare providers in general get to have, but that really fueled my passion for serving populations.
Yeah. Well, thank you so much for both of you for sharing a little bit about your training. One of the things I did ask Dr. Nelson and Dr. Rodriguez to actually share a bit about their professional journey. And I think that's super important because there's something about the two of them that I think it makes them really excellent clinicians. And I think one of those things that, and I know students listen to this podcast, is like where you train is really important and where you serve is very important. And I feel like it really fits your identity of who you are as just people. And again, today's topic is gonna be on diversity and in healthcare, because that's kind of our lane, but we're going to start off kind of just general. Yeah. So let's just be real. All right.
All right.
So tell me like who you are, like meaning like in your culture and nationality, right? Like, come on.
Yeah. For sure. Yeah. So I identify, I am a cis het Black woman. And I am ethnically biracial. I'm half Black and half Italian, but I identify as Black, and specifically Black and not African American. Okay. And for me, not that I don't identify with the larger African American culture, however, for me, as Black culture here in the U.S. has a distinct difference and experiential difference in history than those who are connected to their African roots. And many Black folks who came over here through colonization and enslavement were cut off from our African ancestry. And I don't have that cultural influence from Africa as much as I wish I did. Right. I went through all types of times in my life where I was like, I'm going to just identify with that African side, but I didn't know what that was. So it was just all of Africa, right? And so there is this distinct difference for those who immigrated here, first, second, third generation, that are still culturally tied to their African roots than those who came here not through our own accord and had a different way of developing our culture. We had to create our own that had influences from all of Africa, but was didn't have a singular identity. And I, even though I'm biracial, and being Italian is a huge part of my identity and how I understand the world and how I interact. I talk with my hands. I've already hit the mic once, right? Just being one piece, right? But I engage the world as a Black woman, right? And the world sees me and interacts with me as a Black woman. And so I'm very proud of that. And I'm
Yeah.
proud about how I hold that. And it's important. It's protective and important for me to also understand that despite being biracial, just as much white or Italian as I am Black, that the world sees me and interacts with me as a Black woman.
Thank you so much for sharing that.
Yeah.
How about you, Dr. Rodriguez?
So I identify as cishet Latino male. So my Latino background, I am half Mexican and half Salvadoran.
Okay.
So my dad's side are mainly based out of Oaxaca, Mexico, and Southern California. My mother's side mainly from San Salvador in El Salvador. But I am a first generation college student, and so identify really strongly with all those aspects of my identity. And then racial identity has always been something that's unique for me because looking at me, I'm often white passing in a lot of circles, and in others, people can tell pretty quickly that I'm not fully white, or I'm mixed at least. And that depends on the setting, but and I could go into a whole bunch of that about racial identity and something I talk about with our students a lot. But as far as my culture, like my Mexican Salvadoran heritage and just being Latino, Latin American is something that I hold very closely. And then again, just really ties into my passion for serving the Latin American community in Yamhill County, but then also just broader, underserved people in general. So
thank you so much for sharing that.
Just actually, not to cut you off, but one other thing I think that Dr. Danny and I both have in common, culturally speaking, is also we both grew up here in Oregon and in spaces where we were the only person of color. And so I grew up in Southern Oregon in Klamath Falls, Oregon. So I affectionately call it Deep South Oregon, meaning that it's the last city right before the border. And it's a very rural community. And I was one of, if not the only person of any color in my entire school until my brother came, you know? And so there was also this sense of, the culture being a part of a rural community. So that being part of my background, which people don't assume when they look at me, that I understand and know some of those struggles. And again, talk about an underserved and under-resourced area as well, but also what it means to be the single representation of an entire group of people.
Absolutely. That's a great point. I grew up in Corbett, Oregon. So Corbett High School, Cardinals. I always say it makes no sense to me because Cardinals are not native to that part of Oregon.
They're pretty bird.
They're a nice looking bird. There's a baseball team named
St. Louis. Not in Oregon.
Right. But very similar in to Doc's story in that regard. Very small rural high school. I was the only Latino student in my high school until my sophomore year when my sister moved up from middle school to high school. Then the population doubled from 1 to 2. My claim to fame at Corbett is that I was the first student to pass the AP Spanish test. I didn't
as a native Spanish
speaker. I didn't take the AP Spanish class because they didn't offer one. They're like, well, let's just see if you'll pass the test, and then we can say we've had a student pass the test. And so there's that.
So I'm gonna throw you a couple of things, but we have to talk about this because to me it's so interesting beyond just diversity. I'm gonna talk about identity for a minute. Right. And so, how did you find your professional identity? I mean, you're in these two rural areas, right? A little different than everybody else that you shared with culturally, right? And nationality-wise, right? And I totally get that. I mean, my story is very similar. But again, I want to ask you, how did you find your professional identity? Did you go through many different kinds of identity, I want to say crises, but who am I? Right? As you're kind of going through that, because I think it fits really well with understanding why it's important to understand diversity. right? I mean, I think Danny just talked about it from what he was sharing with us, right? And same with you being maybe the only Black gal and or woman, right? In her area. And so like, how did you find your identity and why is diversity so important to you? You know?
Yeah, I'm still working on it. It's still, my professional identity is still an ongoing process. With that though, I think as to be able to get to where I am now, it was, admittedly early on, it was about blending in, about acculturating and survival, really. I mean, I would routinely hear things from their students like, "Did you ride your donkey into school today?" I mean, I would just kind of laugh it off because I'm like, what am I going to say? I don't really have like no one to back me up if I say anything else, and I just kind of want to blend in. And so as hard as that is for like to think about at the time, like it was really like navigating two worlds, because at home we identified really strongly with our Latino culture, but then at school it was all white majority spaces, and then that continued got a little bit better in college, but I mean Newburgh's not necessarily the most diverse place in the world either, so having to but I had a little bit more space to find myself as a young man and growing into coming into college. And then I think it was really in graduate school where I started to wrestle with okay, I want to embrace all aspects of myself and bring that into my being, but also my clinical work, and be authentic with myself. And I think that really that part in particular really helped me connect with my clients on internship and postdoc with my Hawaiian clients, because they recognize that I'm not Hawaiian, I'm from the mainland, but the fact that I had my own culture that I was proud of, that I was engaged with, and allowed me to respect their culture and their background, it just clicked and allowed me to connect on a level that some of my colleagues couldn't, and I think that congruence, that integration of parts of myself is kind of what I continually try to bring into my professional presence.
Yeah, thank you so much, man.
Yeah.
Thank you.
That's good.
Yeah.
That's good. Yeah, I think similar. I think that my identity across the spectrum, be it my spiritual and religious identity, my identity as a woman, my identity as a professional, my ethnic and racial identity continues to evolve. And the more context that I experience, I start to understand myself differently and understand myself more fully. And I think that when I was in high school, when I was growing up, similar, I think that it was about assimilating in a lot of ways, or trying to make myself small, to not draw attention to my difference, because it was clear that I was different. And there's a really large Dutch population in the area. And so I went to a really small private Christian school, and most of my peers were these tall, athletic, blonde hair, blue-eyed white kids. And then there was me, who was fat, black, and loud. And it just was, I was so trying to find these ways to try and make not necessarily draw attention to myself. Or if I was, it was because I was doing everything and I was overperforming and trying to do these things. And that was how I understood myself. It was like, if I'm going to do this, then I have to be the best, and I have to do all of the things, and I have to do all of the things the best. And when I was growing up, I had wanted to be a medical doctor. I wanted to be a physician. And even in that, I wanted to be triple board certified as a pediatrician, a family doc, and a pediatric psychiatrist, because, so I had all of these dreams, this is what I'm doing. And then I came here to Fox, and again, this area and Fox, especially back in the olden times, in the early 2000s when I first came here. We have grown a lot as a campus in our student body, and it was not as diverse as it is now. I know this number is inaccurate, but the way I remember it was 5 Black students. And I know that there were probably more than that, but the touch point of how many people I would see.
There was 7.
Right. Yeah, it's probably 7. Yeah, exactly. Plus or minus 2. That's how it felt. But given my previous experience, that was way more than I was used to. So I was like, oh my gosh, look at this. There's like other people. And I was still very determined on becoming a medical doctor. And for lots of reasons, I had mentors who really loved me and saw something different in me and tried to give me that feedback. And yet I had a really hard time accepting that. One, because I felt like, who do you think you are to tell me, and where is this coming from? Why are you having this conversation with me and not my peer who's struggling just as much as I am in this class? And why aren't you having that conversation with them? And so I think it took a really long time, and it wasn't until I finished my education that I was able to now go back and look and see like, okay, they were seeing me differently than I was understanding myself. And I can now see that they were trying to say like, maybe there's something else that's better suited for you. But I was very determined and I was like, you're not gonna move me or sway me in this. And then I got waitlisted for med school and I decided to get my master's in counseling. And while I was there, right, I was like, do something while I'm waiting, right? So I went and got my master's in counseling. And part of it was like, if I wanted to be a physician, I felt like I wanted to know, how do I come alongside my patients well? And not just treat them as a patient and their symptoms, a set of symptoms, but come alongside them as a whole person and understand them contextually. And I thought maybe counseling will help me understand that. And while I was in the master's in counseling program, I came across my mentor, Keith Dempsey, Black man, and was the department chair at the time. And I told him my plan, and he was like, all right, well, we'll see what God does with that. Amen. We'll see what God does with that. And he really was somebody that helped me. He was the first person of color that I had in my education. And at that point, I had been... That was my 7th year at Fox or 6th year at Fox. And of course, all of my previous education. That was the first person I had that even remotely looked like me. And I started to be able to understand my future, the possibilities of what it means to be a professional, my own capacity, what I had, my experience and my voice was meaningful. I didn't have to make myself small, but that those experiences were helpful to other people and that I needed to speak into that. And that was a huge turning point for me when I started to really be able to see how being biracial, being Black, being from this area were not things I needed to hide or to try and avoid, but to amplify, because it was an opportunity to amplify other people's experiences and voices.
Yeah, I like that a lot. I think that you two bring up such a good point about why it's important to be diverse or understand that, because I think the word that popped up for me was about being small. Right. And I think a lot about our patients. Who are from different races or going through lots of different changes in their lives, maybe identity in many different ways, and they feel very small, right, and not seen, right? And that's kind of was my story on how I got into physical therapy or even just wanting to be in the healthcare field, because I saw that happening a lot, and I wanted to. It wasn't even help; I just wanted to see them and say, "Hey, I see you." Right? It wasn't like a hero complex. Like everybody thinks like, we're trying to be heroes. Like, no, it's like we identify and say, we're here.
Right.
We see you and we see you for who you are. But have you ever seen this when we're working in the healthcare system? Like people say things like, well, I just think that they should just conform. Why don't they just learn the language? Right. And it's like maybe we've all heard it, right?
Yes.
But what do you think when someone says that as, just sharing with our story about, what it looks like to not be seen, especially when you're not feeling well, right? And maybe you don't have the same resources as a lot of people.
Right.
Yeah. What do you think about that when you hear that in our healthcare profession?
As you bring that up, that just brings up so much. There's so much loaded in that. Why don't they just ...
Yeah.
Why don't you just learn the language? Why don't you just do this, do that? That's an inherently prejudicial statement.
Absolutely.
Because that's saying there's something about you as you are that's not acceptable in this situation.
Right.
Like I cannot, or I will not help you as you are or where you are. I will not make that extra step to meet you where you're at. I would venture to guess that all three of us have heard that in different places, different settings, in clinics. But even with things like translating documents or finding translators for someone who is not a native English speaker, even that is, while still an imperfect way of communication, is taking that extra step to meet our patients where they are, and which is our duty as healthcare providers. We are signing up for this job where we are to help others and we are to provide services, provide care. Like you said, like, people are not feeling well. I'm hurting. I'm signing up to help you. I should be the one to go to you, not you having to take 3, 4, 5 extra steps to come to me. And so I see, like, when we see things like this all the time in different systems. And so I think that's why it's so important for us as providers who have some of these stories, and even for our providers that can ally with us in that, is to break down those barriers, and advocate for the people that cannot speak up for themselves.
Yeah, absolutely.
Yeah, I 100% agree. I think when I hear those things, I just it hurts. It physically hurts when I hear that, because exactly where we are saying that my time, my perspective, and the way in which I encounter the world or move through the world is how everybody needs to. And if you can't do that, then come to me when you can. And I think, it's particularly in the healthcare system, we have signed up to be helpers. We have signed up to meet people where they're at, and it is our job, it is our duty to do our due diligence to meet them and not put that burden on them. And that's what continues to cause the divide in access and care, and even people's comfort in coming into a doctor's office in the first place. If they feel like they're going to be dismissed, or they're not going to be, they're going to be either over or under treated, over pathologized or under treated. They're going to be stigmatized. They're going to have all of these things. Why go into the doctor? Why go there? And it's those comments, even when you think it's an offhanded thing, or I think it doesn't mean anything, words are so impactful. And as psychologists, we know this, like our medicine is words, right? And those comments can deter somebody from coming into the doctor for the next decade of their life, that then set up these generational patterns in their families to not trust the medical system.
That's right.
And so we have to find those ways to, like, talk about how we talk to patients, how we think about patients, how we think about those things, and how we think about them contextually as we're treating them, because it's not just the symptoms. We have to understand them as a whole.
Yeah, and I think you're kind of helping us and helping maybe the people who are listening and watching. How do we meet? What are some of the things that you can think about in your training, in your research, right? I mean, we're all in this together. Right. Like, how do we get to that point, right? And again, in no way am I trying to go away from the original topic, which is diversity. But I think, we can go into maybe some solutions or ideas, right?
Sure.
But beyond that, I mean, even with our research, right? And in our training, like what are some of the solutions do you think that are out there to meet people where they're at instead of just using that? We don't want to break the paradigm, right? It's already broken, right? Medical is already hard to deal with, right?
Yeah.
We're just going to do status quo.
Yeah.
Right?
Yeah.
Or we'll just hire somebody or we'll do something, right?
Yeah,
What would you say are some of the solutions that you think that might be helpful as we move forward, right? In including everyone, especially in the healthcare field, just because that's kind of where we are at and we spend most of our time at, right?
Yeah, I think my brain goes to so many different places. And I think that one, there's an underlying, yes, there's just bias underlying all of this. There's also this complicating factor of capitalism underneath it, that medical systems have RVUs and they have like, how many patients can you get through? How quickly can you turn people around? And as soon as that starts to then cut into your ability to be quote unquote efficient. So if it's going to take me 30 minutes to go find a translator, then that's 2 patients that I could have seen. Right. So there are so many underlying things that really play into it that make it really difficult.
Right.
But I think that first and foremost, I mean, I always come back to education because we see what's being pulled out. We see how it's being operationalized and the health disparities as a result of it. But in order to really change the system, which is what needs to happen, disentangling some of these capitalistic underpinnings and finding a better structure for our medical system. But before we get there, we have to go back to our education. We have to go back to understanding that some of the reasons that we have health disparities comes from underlying biases that are operationalized in how we treat our patients, whether we think they are or not, whether that's our intention or not. There are a couple studies of looking at some really bad colloquial understandings of Black people. And they did this research about 2 years ago. For instance, one example is that Black people have a higher pain tolerance and thicker skin. And they surveyed folks, 73% of lay people, so non-medical people, believe 2 or more of these false statements. The more concerning thing was that 50% of medical students in 2019 believed 1 or more of those statements. So if those things that were rooted in white supremacy and are still cropping up in our students who are being trained to do this work, we have a massive problem, right? And there have been even recent studies that have controlled for like views. So they've looked at like how if somebody has positive racial values and views, does that change how they treat their patients? And when they controlled for even positive racial values, the difference in how what treatment a white person gets versus a BIPOC person, the bias still remained. And so the place in which we can start to systematically target these underlying beliefs that people have consumed without even knowing, have built into their awareness without even, and how they understand people and how they conceptualize pain. Or if somebody looks like this, then that's what pain is. That's not pain, or this is whatever. We have to systematically disentangle some of these built-in understandings that people have that are false. And we start there, then we can start to see the cracks in our medical system, the cracks in the ways in which things are operationalized in the office, in the medical field, in our work with patients.
I agree. I think I've read the same study. And the interesting thing, too, is the fact that they just sent out another research showing funding for anything that's towards equity and diversity. And it's like, I don't know, I think it was less than 5%. I mean, it was something really small. I mean, I can't pull it off the top of my head, but I'm pretty close. I think it was maybe even less than 2%, right? And that goes back to why it's so important to do these studies.
Right.
Yeah.
Right? Because it starts with so much of that. It starts with what is it that we're investigating?
Right.
Right? What are we spending
100%.
time in trying to figure out?
Right.
What does education look like?
Right.
Instead of focusing on, these other things, right?
Right.
And I totally agree. I don't think that the lens is on that in a scholarship or research way. And the funding definitely is not there.
Yeah, absolutely.
Right? And we know these things. And it's not just affecting it's not just affecting the way it's being treated, but it's like bleeding through all of our culture. And
Absolutely.
I think that's one of the things why people are confused, right?
Right.
Yeah.
Like where are all these other things that are happening in our culture.
Right.
And I'm sure you get that while teaching students.
Right.
Right.
Absolutely.
And just overall. So, I'm gonna just kind of throw it back to you,
Yeah.
Danny.
Yeah. I agree with everything that's been said, and I think that with the education is incredibly important. And one of the things that just one additional thought that I had was when I was working in integrated care, for the providers who would be out of their training, out of their residencies and seeing patients, making sure that they were aware of the current literature and of also the historical pieces
100%.
of the medical system. Knowing that, to be able to understand that, it's not that my quote unquote diverse patients tend to have a harder time adhering to their treatment plan, right? It's a why is that? Well, there's actually some pretty intense reasons, historical reasons why some communities just have an inherent distrust of the medical system. You think back to we talked about a brief didactic on the Tuskegee syphilis study, and it was I wish I had taken a poll of how many providers had heard of it, but it was shocking to me how many providers, medical providers, physicians have not heard of Tuskegee, which for our listeners who don't know, was a study started. It was a 40-year study between the 30s and the 70s, where 400 Black men were identified who had active syphilis, and they were told that they were going to be given treatment, but their diagnosis of syphilis was never disclosed to them, and so they were followed all these years and had some devastating ramifications, of course, because they let the disease go untreated. It was spread to partners and family members. Resulted in deaths, and now we look back at that and we're like, how was that ever allowed to be okay? How was that ever a thing in healthcare and physicians, deceiving people like this? But then that's not an isolated event. We see unfortunately in the United States, forced sterilizations have been a huge history marker of becoming out of the false research in eugenics and I have a family member who was personally affected by a forced sterilization, or unwittingly part of it because the documents that she was told to sign were not translated into Spanish, so she didn't realize what she was agreeing to, and when they came to, they had an involuntary hysterectomy. So these things have happened, and they're much more recent than I think than we realize. And so many providers don't if they know it, it's hard for them to connect the dots and that those are still having lasting impacts on our patients and our populations today. So and I think that's where again that we kind of come in with so this happened. We're learning more and more about not only individual trauma but generational trauma and how not only psychologically but physiologically has lasting impacts, right? And so I think that is another area where it's important for us to educate and to bring alongside, to walk alongside, and to make sure that we are as aware as possible of what our patient populations need.
Absolutely. I know all three of us are all components of this, but I think one other piece we have to talk about for education is interprofessional education.
Absolutely.
And I think one of the things why it makes us so excited is the fact that interprofessional education, if those who don't understand it, it means that when more than two groups of professions get together and study or treat a patient, that's collaborative.
Right.
That is not just siloed, right? Like I'm a physical therapist, I just do my own treatment.
Right.
But if a psychologist and a PT get together, that would be interprofessional collaboration or interprofessional education. In our case here at George Fox, which we are building this robust education component for our undergrad, but also for our graduate program, because we know that this is one of the ways that we can educate our patients.
Right.
And educate our students, I should say, to make sure that we get it out, because it's a lean vehicle.
Right.
And it's not based on just tradition, right?
Right.
It's actually breaking silos.
Yep.
And that's what I think why we're so excited about it, and that the focus should be on the person that we're meeting, right? And that's really why interprofessional education is so important. That it's not about so much the process, but it's about the safety, but also understanding the patient. And I think that's one of the reasons why I'm so such an advocate, right, for IPE. And maybe you guys can speak about that, because I know you guys are a component, and I'm going to talk more about it as the future goes of GFU talks and as my role expands. But I mean, is that important to you, right? And have you seen that also at Hopkins and Harvard or in Hawaii, like this understanding of like, breaking the silo, right? But doing it together, not just psychologists alone, not physical therapists alone, physicians alone, right? But doing it together. So.
Absolutely. Yeah. I think interprofessional approach to care is, man, I mean, it's just like 3 heads are better than one, right? Like just even in this conversation, if we're talking about a solution, we all have different lenses, right? And I think that's how I think about just like DEI on the whole. If we bring it back to like diversity education, to diversity, equity, and inclusion, is that it historically has been this perspective of like one perspective as at the head of the table and leads the ways in which we all have to now do it.
Right.
And kind of decentering that perspective and saying that is a perspective, and not to say that it needs to go away, but it is one of many. Now let's bring all of those other perspectives to the table so that we can actually understand whatever it is that we're looking at or whoever we're dealing with from a variety of angles and from a variety of perspectives and experiences. And that's what, interprofessional care really is saying like, I can bring my expertise and knowledge from a psychological perspective, also my own lived experience as a woman of color here in this area. You get to bring your knowledge and expertise as a physical therapist, as a medical provider, and we all see the same person and the same symptoms, but may have a very different take on that. And somewhere in the middle of that is the truth, right? But what has happened before is that we were all operating on multiple truths, and the person, the patient got lost in the midst of that.
Yeah, absolutely.
And so for all of us to work together gives them an opportunity to be seen and cared for as a whole person and not just picked apart on one little piece at a time, that then actually those puzzle pieces don't actually add up together to make a whole.
Yeah, absolutely.
Yeah.
Yeah, I love that explanation, and I agree completely. And I think it helps it be more equitable,
right?
Right,
Absolutely.
versus these pieces, right? So the more the lack of resources some of these areas have, that you guys have already experienced through your training,
right?
And that we have here in the rural area, right? Can then become more shared by this experience or care, right?
Yeah, absolutely.
How about you, Dr. Rodriguez? What do you think?
Yeah, I as we're talking about this, it just kind of brings to mind an example of a patient experience that I had while in training. It was a young man about early 20s, and had recently been moved back to the islands to live with family there, and he had recently had her first psychotic break, and on the mainland was wandering large lakes, just large distances, excuse me, and very active delusions and hallucinations, and not taking care of himself just hygienically, and so led to a number of physical issues as well, and basically family on the mainland said that we can't take care of him anymore. We need to send him back to Family Islands, and he shows up in my office as an intern, and so like I'm talking with him, and he's showing all the symptoms, just very classic symptoms of schizophrenia, and it's like this kid needs help. He needs a lot of help, and so as an intern, I was operating under my supervisor's license, and consulted immediately, saying like I am pretty confident that the kid has schizophrenia. I think we need to get him connected with primary care provider, like a psychiatrist immediately. Also, probably wouldn't hurt to get him to see a dentist and just to see a physical therapist, because he's limping and all this stuff as well. And thankfully, because of this system that I was in, all of that was available to him.
Right.
Wow.
So I immediately was able to consult with our psychiatric nurse practitioner, who was willing to start him on an antipsychotic until he could see a psychiatrist, and he got connected with primary care, got connected with all these other pieces.
Right.
And within a couple months, he comes back, and it was almost like a completely different person.
Right.
Obviously, still had his diagnosis, but was getting the care that he needed, and it was accessible. And so he was not suffering anymore. There wasn't any needless suffering happening anymore.
Yeah.
And I think like this is how the system should work.
Right.
This is how it should work, because all of us like being able to collaborate and contribute the skills of the training that we have to be able to allow our patients to flourish and be the best version of themselves. And that is really what IPE, what I hope for, what I think it can be. As long as we take down those barriers that keep people from being able to access it, right? And so I when Amber, when you were talking about just kind of looking, everybody, we were in our silos, and everybody was trying to look at it. It's like that old story of the blind man looking at the elephant, right?
Yeah.
Everybody had a different piece and was filling out the piece and trying to do their own thing, but then ultimately none of them knew it was an elephant, so that like it was missed, right? And so we're trying to go about it a different way.
Yeah. I think that's why I'm so excited about what we're doing. I'm also excited about healthcare.
Yeah. Yeah.
And it's because of this type of collaboration.
Right.
I mean, again, I think if we just saw it from our own self and our own discipline, there's a lot of things that are happening that may make us a little bit more discouraged.
Yeah.
Right?
Yeah.
But I think when we put ourselves together and we start thinking about it in a collaborative standpoint, I think it's exciting, right?
Absolutely.
On how much we can learn from each other,
100%.
right?
Yeah.
And how we can then also help the patient together,
Yeah.
which I know that I've already experienced with Danny, being able to work together with him in primary care. And so I'm really excited about what that looks like. Yeah. I just want to ask maybe just one more perspective, because we've talked about our identity, we've talked a little bit about our journey, we've talked about some solutions, diversity, but I wanted to ask you about your faith, right? I mean, that's probably one of the reasons why you came back to be professors, even though you probably could go anywhere in the country and do that you came back to George Fox for many reasons, but I think one of it is the faith component, in the sense of it being central of who we are.
Yeah.
And so how has your faith been, right, through these times, through the times of what we're living through, right, as we are learning our identity and trying to figure that out? Like, how's your faith been through that experience?
Yeah, that's a great question. I'll be honest, that there's times that it's been challenging, and like you said, discouraging. That the immense need, and then that was only exacerbated within the pandemic and the socio-political climate, just the pain that so many were feeling and then at times feeling like inadequate, like I'm like, Lord, I'm just one person. What can I do to when it feels like it's just a drop in the bucket, like the old cliche says, and I think that at the same time, coming back to George Fox, really was a sense of calling for me to be able to step into this role of mentorship and teaching of students. One, because I especially for the BIPOC students, I can relate to what it's like being in a graduate setting and trying to navigate that, especially if for myself, as I mentioned, I'm a first generation college student and wanting to create a sense of belonging for those students, but then training them to see our patients, our clients as a whole person. And like I've been saying, meeting them where they're at, because I really see that in like just my faith informs my practice in the sense that I try to say, like, I think this is how I'm the way I think I'm doing it is I hope the way Christ would do it. In the sense that, like, Christ would break down barriers. Christ would take those extra 3-4 steps. Christ would want the marginalized to get the first fruits, right? And so those have been the principles. Like I think that who I view Jesus as and who I view the Lord as is like that is how I want to model what I do and what I teach my students. Even if it's not always explicitly stated, like I'm not always talking about faith integration. I do talk about it in the classroom, but even if it's not always explicitly stated, that my heart for patience comes through, and then really it's my faith that informs that, even if it has been difficult at times.
Thank you so much for sharing that.
Yeah, no, I agree. I think similar that for me, in particular, I mean, across your life, right? Your faith should be challenged. It should. You should never go in any part of your identity without ever questioning or ever being challenged by aspects of it. Because if you're not, then you're not growing. And I think that the last couple of years have been very challenging, and also really this opportunity for a lot of growth. And it has required some deconstruction of my faith to kind of disentangle things that I think were infused in my understanding of Christianity that was not actually theologically sound, or wasn't actually the theology of Christianity, but what the culture of what U.S. Christianity is, be that politics or other understandings, and ways in which we ask Christians to behave in a certain way that aren't theologically grounded. And so there's been a lot of that time of me kind of coming to that reckoning of saying, like, this is my faith. I believe this with everything. And how do I tease apart some of these things and be okay with letting go of some of those things that are not core to what it means to be a Christian? And how do I now reconstruct, my faith in a way that builds in this new understanding and a more, for me, grounded in theology way of understanding my faith and me in context. And part of that also was, again, acknowledging the role Christianity has had when it comes to racism and colonization, and how Christianity has and continues to be weaponized against different cultures and belief systems and underrepresented groups and disenfranchisement, and be it U.S. or globally. It's hard. It's heartbreaking to see and hear that it continues to be the thing, but that those things don't define my faith, and that how do I disentangle that and rebuild my sense of what that is and how I live in that. And I too hope, even when I'm not talking about it explicitly in my class or with my patients, that the ways in which I live my life, the ways in which I prioritize meeting people where they're at, going out of my way and loving people, no matter who you are, or what you've done or what you're doing or whatever, that is the operationalization of Christ's love for us. And that the overarching, theme and message of Scripture is love and redemption. And how do I enact radical love and redemption to everybody that I encounter?
I love that.
Yeah.
As you guys have been speaking, that is exactly what I was thinking about, was actually love, right? And how what we're talking about is like this agape love, right?
Yeah.
And beyond that is even like brotherly and sisterly love,
Absolutely,
right?
yeah.
And I think, that's all tied in. But at the second time while you were speaking, I just thought about this word, right? Which is wisdom. And I think that we're becoming wise through this time.
Yeah.
Because I think I think same with me. I think I was angry for a little while.
Yeah.
Right? I mean,
For
it would
sure.
have to be human,
Absolutely.
emotion, right?
Yeah.
Growing up and feeling angry and almost feeling distrustful.
Yeah.
And I think that when we read the scripture, we see the same thing, that disappointment, right?
Yeah.
But then if you hang in there and you continue to lean right in the arms of Christ, that here comes love, and then here comes wisdom, right? And I think that's one of the things that we have a privilege of doing, is actually sharing wisdom, right? As professors, as people who are treating and being clinicians for. And I just think about that. And how do you think that we can continue to harvest wisdom or train wisdom, right? As we're moving forward about diversity, instead of just educating people, right? Because there's a little difference about being wise, right? There's a difference about just being an educator, but being maybe someone who's more of a mentor. Right. And I think we can do both. I mean, that's how I see myself. Right. I've been practicing for 20 years, but I've been in academics for almost 9. And I see myself an educator, but I also see myself as a mentor. And I think we got to redefine what professors do for work.
Absolutely.
Because we used to think that we would stand and deliver. We'll do some research. But I noticed that more and more people are wanting to be in community with us.
100%.
I mean, I'm sure you've noticed that, right? And mentorship is like one of the number one things that I feel like students are looking for. And I think when we signed up to be professors, that wasn't something that was on the job description, right? Like, you're going to be a mentor, right? To BIPOC or to, wherever God's called you to.
Right.
And I feel like that's the one thing that's being redefined in our work as professors. That's a different, and it's almost like service and teaching and scholarship all
in one.
In faith, right? If you think about it. And I think it's like another category we really need to think about, because it's going to take up a lot of our time.
Absolutely.
But that's what the students are like going away with.
Absolutely.
Right? They're like, I'm in relationship with Dr. Amber and Dr. Danny or Dr. Kang, right? That we're in relationship. So maybe we can finish off with that, like mentorship and how to make a wise counsel or make a wise community, right? So,
absolutely. Yeah, I think, our department as a whole, and the clinical psychology department, we emphasize mentorship a lot. We have ways that we build things in, and also every person does mentorship differently. But I think that you're absolutely right that for me, I have seen, somebody can do academic work and not have built the wisdom, not have done the character formation, and not have done the work to step out in a way that is grounded and crunchy and has texture, that is a fully realized self. And it's really easy as students, having not that long ago, but a student, as students to come in and think like, I just have to like get A's. I just need to do the work. But when you do that, it's so disconnected from the experience of being a person, the experience of being a professional. And I talk to my students all the time, like, it's about the process, not the product. And I care about you and all of who you are more than you as a student. And if there's something going on with the who of who you are, we need to sit with that. And of course it's going to affect you as a student, but I care about it, but that's not what we're talking about here. There's a piece of what it means to be a mentor is to help our students not only contextualize their patients, but contextualize themselves, to take the time to think of themselves holistically and not to center only one part of their identity as a student, their academics, to the detriment of every other part of themselves. Because we see that happen so often, and then they, finish and they have not learned how to have a balanced life, and they burn out immediately because their whole life has been their profession and their academics and doing and performing and this and this and this, and not being a whole person and not doing the formative pieces around how do I integrate this part of my life with all of the other parts of who I am. I'm a mother, I'm a sister, I'm an artist, I'm this, I'm this, I'm this. You have to find ways to still invest in all of the parts of who you are while also doing this academic work. And if you can't do that, you're not going to be able to go there with your patients, and you are doing yourself a disservice because you're setting yourself up to burn out so quickly. So what does it mean for us to step into that? And for me, particularly as a diverse person, as a BIPOC woman, I also used self-disclosure. I share my own journey. I share my struggles. I'm somebody who has ADHD, right? And so there are lots of things that I have to do differently that don't fit in the typical system in order to still make it. And how do I share those things and come alongside my students and not just say well, you're not timely, so you're never gonna make it. Well, no, it's a struggle for me too. Here are the things that I have to do. Here's how I've had to rethink it. Here's what I do, and allow myself to come to the table just as much as they are.
Thank you. Yeah,
absolutely. As you're mentioning that, Amber, I think of, I too am really relational in how I go about mentorship. I just, like I mentioned, I just value being authentic in myself. That's how I go about my mentorship, relationships too with students, is that this is who I am. Who you're talking to in my office. I'm the same person that you would talk to if we met up for lunch somewhere. Yeah, maybe if we met up for lunch somewhere, I'd be wearing a t-shirt and tennis shoes, but maybe a little bit more chill. But I'm the same person, right? And this is who I am. This is how I've learned to navigate, or to navigate the system, how to apply these concepts, and how to conceptualize everything in a way that seems consistent with how I see the world. And I think about how I started out my my class that I taught last fall about cognitive behavioral therapy. A lot of students come into the class with kind of preconceived notions of CBT, in the sense that for those of you listeners unaware with CBT, kind of has this reputation of being kind of cold or distanced or just not very relational. And how I start off is my goal is not to convert you all to CBT therapists. My goal, though, is to hopefully show you a different side of CBT, and show you kind of what the possibilities could be. I'm if you were to shadow me and watching me do CBT with a client, you might come away thinking that's not CBT. That's not what that looks like, because my style is just more interpersonal and relational, just because that's who I am. And I think that's what I bring to my mentorship as well. And what I want for my students is I want them to learn from me and learn all these things as well, but I don't want them to be me.
Right.
I want them to be them, be the full, like I said, I want our patients to be the fullest versions of themselves. I want my students to be the fullest versions of them, because what they have to offer is exceptional. I don't want to make carbon copies of myself or carbon copies of Doc Nelson, although that would be awesome. But and then I just wanted to touch on what you mentioned when you first asked, how do we foster wisdom?
Yeah.
Like the first thing that comes to mind is like, sometimes it's like, shut up and listen.
Yeah.
Right. Especially as professors, like, I mean, as early career professorship, it's like the struggle with imposter syndrome is very real, but
100%.
we come into it, it's academia. It's really easy to kind of like, I imagine it's really easy to come into like, I have my knowledge base, I have my training, I completed my doctoral education, I know something about something. But it's I think for that goes along with, we can have all the academic credentials and still be fools, so to speak, right? If we're not listening, if we're not like, if I'm not listening to you, Dan, and what you bring, like what you can bring as a physical therapist, as a person, and like I'm being foolish because I'm shutting myself off to potentially a wealth of information, a wealth of knowledge that I could learn from you. And I've been trying to do this more and more with my students is, what can I learn from my students too? Right? What can I learn from their life experiences? Because and even if they're not as far along in their training as I am, there's always something that I can be gaining from them. Like I could gain something from my students, I gain something from my peers and senior faculty. But I think that also gets to some of the core of what we're seeing nationally is that people aren't listening to each other anymore. Right. If we're hearing, but we're not listening. And I think there's a very distinct difference. And we're not trying to, whenever we feel the slightest threat, we retreat and we don't kind of sit in there, which I think is which I think is the important bit. If we're gonna build wisdom, we're gonna have to listen even when things are uncomfortable or we disagree with them.
And it requires humility, right? And I think that humility and responsivity, right? It's like we have to be able to humble ourselves, both as educators, as mentors, stepping into the space with our trainees, but also training them, helping them to find that sense of humility, regardless of your training. You could be the expert, which I actually don't even like to use the word expert because it puts you in a position to think, well, I can't learn anything from anybody else. I'm the one that knows everything, right? But like, even if you are the forerunner of whatever, you always have so much room to learn from everybody that you encounter. So how do we use humility and responding to those around us as that core to like building that wisdom?
Yeah. I see that with the two of you, honestly, and can't thank you enough. I see so much humility, and I hope that you also know that through that humility, I see confidence. But it's not confidence in just oneself or expertise, but it's just confidence in, like, it's not the process, but there's confidence in your faith, in your experience of who you are and like what you're becoming, right? And I think that confidence is so needed. It's not cockiness. It's not pride. Right? It's something completely different. And I want you to know, like, I share this a lot with my students, like, your training matters. Right. How you decide where you're going to go and get trained. Right? This experience, these things that stretch us. Deciding to say it's going to be okay to be uncomfortable. Right. Going to this island. Going to, for you, going to the East Coast, right? To these two, schools that are doing things completely different than what you've received here. Me moving from Southern California to come up here to stretch me, to stretch you, comes this opportunity for wisdom and love and humility, but also comes this confidence in the Lord. And in confidence in the training that we received. And I think the students sense that, right? They sense that because it's our life story, and it's our life journey. And so I just want you to thank you so much for sharing that time with me and being able to discover maybe what it looks like a little bit more, having a discussion around diversity, right? And I would say, reach out to us, right? If this hits a chord with you, right? Reach out to us. We're here. And I think it's part of who we are as wanting to make sure that we are reaching and that we're available.
Absolutely.
Any final thoughts?
Thank you, Dan. I really appreciate you for inviting me to be part of this conversation, and with Emperor as well. Just two people that I just have the highest respect for and love hanging out with. So I had a blast. Thank you.
Yeah, of course.
Yeah, same. Yeah, thank you. This is a great space to just have this conversation, and there's so much
Yes.
to the conversation
so much.
In healthcare and
do a whole
DEI and
series.
every part of this. And so, just thank you for us to have this opportunity to talk. And yeah, absolutely. If anybody wants to continue the conversation, has questions, come find us.
Yep.
We're in the Roberts Center.
We're in the Roberts Center.
Exactly.
Come and find us. Knock on our door.
Well, I'm gonna come find you.
Sounds good.
Yeah, thanks for everybody, and thank you too again. And I really believe that the future of IPE, psychology is so bright. Having two of you here, and also just sharing your vision of what it looks like to be diverse, to be inclusive, and also to have a faith through that, and being mentors and professors for our community. So thank you very much.
Awesome. Thank you.
This has been a production of George Fox Digital. If you like what you're hearing, subscribe to George Fox Talks on Apple, Spotify, or whatever you're streaming on. Check us out on the web at georgefox.edu/talks, where we have videos, publications, and more. And we're also on YouTube at youtube.com/GeorgeFoxTalks.